Copper and manganese, what's unique about these two is that these are cleared not by the kidneys or the GI tract. They are cleared by the common bile duct that drains the gallbladder into the duodenum. So whenever you have obstruction to this common bile duct, they tend to accumulate. Only I want to raise the point of manganese. Manganese as an element tends to accumulate over time and accumulates more so in someone who don't have a functional bile duct. When it accumulates, it goes into the brain and it causes neurotoxicity. I have seen it frequently during my career in patients developing severe headache, Parkinson-like symptoms. They come to us and we do an MRI to the brain, and typically the radiologist can read, it tells you this is a manganese toxicity, so you'd have to take all the manganese out of the parenteral nutrition. Multivitamins are very important. Please do not omit them from TPN, especially the water-soluble vitamins. Especially the water-soluble vitamins that are not stored for long in large quantities. Now, I know the vitamin B12 is an exception. Vitamin B12 stays much longer than any other water-soluble vitamin in our body. But for the rest, B1, B2, folic acid, B6, please, every TPN should have the multivitamins in it because they can get depleted easily and they are essential for the metabolism of macronutrients. Think about how important vitamin B1 is for the metabolism of dextrose. We've seen cases of vitamin B1 not added to the TPN. Patients develop lactic acidosis. It happened in 2 kids back in 1999 when there was shortage of vitamins in the US, and 2 babies died because B1 deficiency. And the carbs need that B1, the thiamine, for metabolism. Otherwise, it went to make lactic acid, neurological toxicity, and possible death. Quickly, because we are running short on time, TPN, yes, is a life-saving therapy. It needs to be monitored by specialists, pharmacists, nutritionists, physicians, sometimes social workers. It's a teamwork. And this is how I did it for almost 18 years in the United States. It's a teamwork. It starts from the nutrition assessment to the delivery, to the infusion of the therapy, and to the monitoring. It can be associated with many complications. I have here listed the metabolic complications. You have to watch out for the hyperglycemia because you're giving a source of dextrose. The dextrose that you give should not be the cause of hyperglycemia, but you happen to be given this dextrose in the TPN to someone who is really ill, whose body is on fire, I would say. They have stress-induced hyperglycemia, they have sepsis, organ failure, and they could have other sources of glucose, or being diabetic, have pancreatitis, or receiving corticosteroids that would exacerbate the hyperglycemia. Hypoglycemia may happen whenever you suddenly stop the parenteral nutrition. We call it reactive hypoglycemia. We've seen it also happening when we add the regular insulin to the TPN and we forget about the dose or the insulin in the TPN, and patients would drop their blood sugar, unfortunately. Increase in serum triglycerides called hypertriglyceridemia. This is mainly due to too much feeding from dextrose. Yani, the main cause of high triglycerides, as is in our regular diet, is taking too much sugar. Sugar gets converted to triglycerides. So when you have a patient on parenteral nutrition and develop high triglycerides, first think about the dextrose. Am I giving too much? That a lot of it is being converted to make triglycerides. Then you think about, okay, is it the fat? Probably. Maybe I should reduce the dose of IV fat or use a solution that is 20 or 30%. Overfeeding is a no-no. We are pharmacists. We don't overdose. Think about parenteral nutrition as a therapy that the pharmacist can handle and should be responsible for it, equally responsible for it. You do not overfeed. You calculate your calories and you give what the patient needs. Overfeeding can cause a lot of complications of metabolic and infectious nature, and it suppresses the immune system. We put a lot of fluids in the TPN. We talked about fluid overload, electrolyte. Please be careful about the potassium, major risk, and the calcium phosphate compatibility. And of course, to a lesser extent, the acid-base disorders. Too much acetate can be converted to bicarbonate. The refeeding syndrome is the population. It happens with parenteral nutrition, with oral diet, with enteral diet. It's when the body basically has been starved and you start feeding very quickly. So insulin is increased. You have a drop in the potassium, magnesium, phosphorus, loss of water-soluble vitamins. So in someone who is at risk for refeeding, such as those who have lost significant amount of weight, then you start your parenteral nutrition very low, slowly advance. مساء الخير جميعا، يسعد مساكم.
مساء النور.
أنا بتشرف إنه أكون معكم الليلة كمدرسين، كأساتذة جامعات وكتلاميذ بكلية الصيدلة، لأحكي على الموضوع البارنترال نوتريشن يلي هو جزء كثير كبير كان من حياتي المهنية، ويلي قدرت ابني حوالي كارير كاملة، وموضوع كتير عزيز على قلبي. بقى رح يكون أكترية حكي إنجليزي وأوقات بحكي بالعربي، وإذا في أسئلة كمان ما عندي مشكلة أخذهم بآخر المحاضرة. بعرف إنه صارت عشية هلأ ووقتنا ضيق، عنا شي ساعة تقريبا. بقى رح بختصر الموضوع بطريقة إنه شارككم بالأفكار يلي هي أساسية وإلها علاقة بالتغذية الوردية أو البارنترال نوتريشن. اسمحوا لي إنه حط الباوربوينت برزنتيشن هلا وبنمشي على أساسها. Good evening everyone. قادرين تقشعوا PowerPoint presentation عندي؟ واضحة الصورة؟
نعم دكتور، واضحة. نعم دكتور.
ألو؟ واضحة؟
نعم دكتور.
جدا، شكرا.
نعم واضحة.
So I will be sharing with you this evening. تسمعوني ايه؟
نعم دكتور.
So tonight I will be sharing. Yes, I will be sharing with you a lecture giving the gist of parenteral nutrition. رح نسميها يا إما total parenteral nutrition أو parenteral nutrition. It refers pretty much to the same thing. So what is parenteral nutrition and what goes in it? By definition, as you can see on the screen, it is the administration intravenously, intravenous administration of a complete and balanced nutrition formula. It's very important to keep in mind, when we give parenteral nutrition, we give it via veins only and no other way. Meet a patient. These are very important. A formula will contain fluids, a major source of fluids, alongside with the electrolytes. The sources of energy, we call them the macronutrients, and these refer to the amino acids, the dextrose, and the fat or lipids, along with the micronutrients. We call them micronutrients not because we don't need them in enough quantity, but also because the body has typically a lot of reserves of these for the most part. So these include the trace elements or minerals, we'll go over them shortly, and the mix of vitamins. So when you design a formula for parenteral nutrition, it should contain all of these elements unless you have conditions that require to give a little bit less of one or the other, or give more of one or the other. So why do we provide parenteral nutrition, and when should we give it? So the purpose of giving IV nutrition, I mean parenteral nutrition, is either to preserve or replete the lean body mass of the person and the visceral proteins, to support anabolism, i.e. building tissues, and promote a positive nitrogen balance by the mere fact of giving all the energy sources, including the proteins, the dextrose, and the fat. And at times we give parenteral nutrition to promote weight gain or maintain the patient weight, depending on the situation. We have to acknowledge the fact that parenteral nutrition is a life-saving therapy, but it should be used only under specific conditions whereby the oral or enteral routes cannot be used or should not be used. In other words, if you have a patient who cannot or should not eat, or a person is not benefiting from placing a feeding tube to feed them inside the intestines, and you have waited long enough and you could not use the GI tract, then this is when parenteral nutrition becomes essential. So when you walk into the pharmacy where parenteral nutrition is compounded, or you walk to the patient's bedside in a hospital, how do you see all of these mixed? How do they look like? I'm gonna start here in the middle and show you, this is a bag of a nutrition formula that is meant to be given intravenously. It has the fluids in it. It contains also all the macronutrients, I mean the amino acids, the dextrose, and the fat or IV lipids. It's the same when you say IV lipids or IV fat. These are the sources of calories. It has also electrolytes in it, the trace minerals, and the vitamins. The reason you see it with this color that is a bit yellowish, sometimes it is more of a yellow to pinkish or so. So this color is because of the vitamins. If you take the vitamins out, it would look transparent. However, if you look at the right-hand side here, you see a similar bag to which the fat was added. In this one, there was no IV fat. Okay, so the yellowish color, sometimes orangey, I'm sorry, I said pinkish, no, it's orangey. So this tells you that there are vitamins added. Here, everything is in it, but we added this fat. See this bottle? So we mixed everything all in one. And this one, you give the fat separate from the rest. So the white color represents the fat that masks the color of the final product. If you look at the left-hand side of the screen, nowadays, a lot of hospitals are using a type of pre-mixed parenteral nutrition, which means they come from the manufacturer ready for use, but these are more of a generic formulas that caters to the majority of patients, whereby you have standard amount of fluids, electrolytes, nutrients, calories, etc. And there are some benefits to it, as the pharmacy inside the hospital would not have to prepare each and every solution for the patient. There is also some money saving on them. At the same time, there is a potential to reduce errors in the compounding as well as infectious complications. But again, they do not benefit all the patients because they're more so standardized to those who don't have a lot of complications, patients who don't have renal problems, liver problems, or fluid issues. So you see here at the left-hand side that these are 3-chamber bags. They are separated. They're not connected. Before you hang them and infuse them into the patient, you activate them at the bedside. Basically, you pull them apart and everything mixes all in one. So on one hand, on one solution, on one side of the bag, one part of it has the fat. The other one may have the amino acids and electrolytes and the fluids in larger amounts and the vitamins, etc. You can add them at the bedside. They don't come with vitamins because they break down easily. And on the other hand, you could have the amino acids separately. The reason why the manufacturer, they don't mix them all together because of incompatibility issues. Because when you mix a TPN, you're supposed to use it within 30 hours of compounding and within 24 hours after it goes into the patient. So it doesn't last for too long. For this reason, the pre-mixed bags, they come in different chambers. You activate them at the bedside, and then you infuse them within 24 hours. So again, when do we use parenteral nutrition? And I would like to emphasize this point very importantly, is that TPN is important. You may see patients receiving it for a week or 2 or 3 or months, but I've seen patients receiving them for years and years at home. They live on them. Examples of those patients who get them for so many years are those patients who don't have a functional GI tract. Patients who are young children who had a lot of their GI tract resected, surgically resected. So on the right-hand side of the screen, I would like to share with you this schematic. It's more so of a thought process that you go through before you consider any type of nutrition, if you follow with me carefully here. So of course, at first you have the nutrition assessment that is typically done by a nutritionist or a dietitian. However, a specialist in nutrition support who is a pharmacist can also aid or help the nutritionist in the assessment easily. So after you do the nutrition assessment, you check the patient's GI function. Can you use oral or enteral nutrition? Because these are the first thing you consider before you go into the parenteral nutrition situation. So if the enteral nutrition is acceptable, which means that the patient is okay to have his or her GI tract used, then you consider placing a tube feeding for short-term or long-term. Without going further into the detail, then you check the GI function again, and you can use any enteral formulas. So if this part does not work, then you go to the IV or parenteral nutrition. When you consider parenteral nutrition, you have so many indications on the left-hand side of the screen. We'll go over them. You think about it this way. Would it be a short term? Am I doing it only for, let's say, 5, 7, 10 days? If so, I could infuse the TPN via a peripheral vein without having the need to place a central venous access. If it is a long-term issue, then I would call it a central TPN, whereby I can mix a highly concentrated formula, and I would infuse it after I would have a central venous access, a catheter placed. Now, having gone through this schematic, let's go back to the left-hand side of the screen. What are, again, some of the indications that are just few examples for parenteral nutrition? Before I get to them, let me give you an idea. If you have an adult patient, someone who's an adult, who hasn't lost any weight recently and is not malnourished, they can easily go without any nutrition for a good 5 to 7 days without any harm done. During these few days, they can be supported with intravenous fluid that contains some dextrose, some electrolytes. If you want to add vitamins, it's fine. That's in the case of an adult who has enough reserves and has not lost any weight and is not at risk for malnutrition nor is malnourished. Of course, those 5 to 7 days do not apply to children because they can easily lose weight, they don't have enough reserves, and they need to grow. So indications of parenteral nutrition on the left-hand side of the screen with the blue background. Definitely, I'll pick one example here that is really important, is those patients who develop what we call short bowel syndrome or malabsorption syndrome. A short bowel syndrome develops in patients who lose, by surgical means, following surgery, significant lengths of their small bowel. And for the children, they may end up with less than 100 centimeter of small bowel remaining. For the adult, less than 120 centimeter of small bowel remaining. If you don't have parenteral nutrition, how could those people either grow or even live? So we end up putting them on long-term parenteral nutrition. They don't have enough bowel length to absorb nutrients, and they have continuous diarrhea. This is a good example for long-term parenteral nutrition. You're talking about years receiving it at home. They receive it at home. Think about other cases. Let me take the case here of severe acute pancreatitis. And I like to dwell on this a little bit because most cases of acute pancreatitis, iltihab al-pancreas, they don't need parenteral nutrition. If it is a mild pancreatitis, in a few days, they will regain oral intake and they're discharged home. But when you face someone with severe pancreatitis, the pancreas has necrotic tissues, and it is a hypermetabolic, hypercatabolic disease, severe, whereby the patients can become really malnourished. They break down their tissues. Then you cannot use the GI tract. Most times the GI tract is not working. Then you put them on TPN until they have a return of the GI function and their pancreas heals. Another good example also is somebody who has a lot of diarrhea that is continuous. It could be related to radiation enteritis. I give this example because some patients who get exposed to radiation therapy a lot, frequent radiation therapy, they could develop GI toxicity, gastrointestinal toxicity. They have diarrhea going on for days, weeks, and months. Those patients end up also on long-term parenteral nutrition. The last example before I move on to the next slide is I cannot but address the babies, the newborns, the patients who end up in the neonatal intensive care unit, whereby you cannot feed them. You cannot feed them because they have problems with their GI tract. Those babies badly need parenteral nutrition to build tissue, to grow, and to support their immune system. Moving on, how do we give parenteral nutrition again? It was mentioned earlier in the schematic I showed you. Either the parenteral formula is infused via a vein that is peripheral, not a central one. And this is meant only to be for a few days, because the TPN itself can irritate the veins. And as you know, the peripheral veins are smaller. They have a blood flow that is not fast as is in the central vein. They're not as strong, as sturdy, so they can be hurt really easily. That's why we keep it for a few days only. And if you give peripheral parenteral nutrition, you cannot concentrate it much. If you concentrate it too much, you increase the osmolarity of the solution, and this would cause also damage to the veins. So for us as pharmacists, you, I, and everybody else here, is that anytime you have to give a peripheral solution infusion, be it parenteral nutrition otherwise, make sure that the osmolarity of the solution giving peripherally via a small vein, such as the antecubital, has an osmolarity that does not exceed 900 milliosmol per liter. Anything higher than this could cause vein damage and must not go peripherally, but rather via a central, larger vein. So the osmolarity of the parenteral nutrition solution comes primarily from the amino acids, the protein sources, as well as the dextrose to the great extent. Of course, other nutrients, other substances do contribute to the osmolarity, but the majority of the osmolarity comes again from the amino acid solutions and the dextrose. Best way to provide a balanced and complete TPN is via a central vein. You have here a chance, a leverage, whereby you can maximize or optimize, I would say, your macronutrients without causing any damage to the vein and without needing large volumes, because the concentration, the tonicity, and the osmolarity matter when it comes to peripheral. In the central vein, when you go into subclavian mostly, and I have here a schematic of where the peripheral catheter or the central catheter end up being inside the veins. So the tip of the catheter goes into a large vein where the blood flow is high. So you can this way give higher osmolarity solutions, whether it's 2000 and over. Your solution can be concentrated without risking any damage to the vein. You can optimize the fluids, especially if someone is fluid overloaded, renal failure, heart failure patients. So this is when you can be comfortable giving an optimal parenteral nutrition by placing a central venous access placed typically by physicians, by surgeons. Sometimes we have skilled nurses who can do that, depending on the type of the catheter. And again, this is the best way to provide a complete and balanced formula. Let me refresh your memory again. I showed you that now we see a lot of pre-mixed parenteral nutrition. They come either as 3-chamber bags or 2-chamber bags. What I showed you earlier was the 3-chamber bags. Sometimes they come without lipids, okay? They are activated at the bedside before administration. These are quite commonly used for the advantages they bring to the pharmacy and to the hospital, cost-wise, less chance of contamination of formulas, less labor within the pharmacy. But again, one size does not fit all. They are more so standard for the patient who doesn't have much of problems such as organ failure or otherwise. When you think about parenteral nutrition, of course you think about calories, but you have to remember that these bags can provide a lot of fluids as well. So as a pharmacist, you have to tailor-make your parenteral nutrition formula to optimize the amount of fluid, the total fluids that this bag is gonna provide over 24-hour infusion. And this amount of fluid must be factored in the fluid tolerance of the patient. Let's say if you have someone, an adult, who weighs 70 kilograms, does not have any fluid issues, meaning he has good kidneys, he doesn't have any heart failure, whereby you have to restrict the fluid intake. So in this case, you say a 70-kilo patient requires around 2 liters or 2.5 liters as maintenance. So this should be considered by you and by the nutritionist as a source of fluid that can be major. But for this patient with good kidney function, no heart problems, no lung problems, a 2-liter bag would be just fine. So keep in mind the fluid balance whenever you give TPN. I can give you a quick example whereby some patients were placed on high volumes and sent home on parenteral nutrition for months, but they were not followed up closely, whereby they didn't need as much when they go home of fluids. They presented back to the emergency department with fluid overload causing heart failure. So the assessment of parenteral nutrition needs should happen on a regular basis, if not on a daily basis, depending on the condition of the person. Let's go now over the macronutrients. The macronutrients are those that provide us with the calorie, with the energy. Let's begin with the amino acids. They are the building blocks of proteins. When you think about the amino acids in parenteral nutrition, you look at the solution itself, it's transparent. It's a mix of essential and non-essential amino acid. It comes to you ready. Of course, those amino acids are mostly age-specific, which means in your pharmacy, in the hospital pharmacy, you have formulas specific for the adult population. Other formulas are prepared and made of amino acids by the manufacturer for the children. Others are made for those premature infants. And these are prepared based on the needs by age to simulate the normal plasma concentration of amino acids in an individual. So they come to you all prepared with a nice mix, nicely balanced, and they are age specific. So you have to make sure that the patient get the right formula. Also, they can be disease specific. There are amino acid formulations that come specifically for those with liver dysfunction or kidney dysfunction. So why do we give amino acids? For so many reasons. Either to preserve the lean body mass, the muscle mass, and or to counteract the effect of catabolism. When you say catabolism, you know by now, it's the breakdown of tissues. Imagine someone who's very ill in the intensive care unit, who is septic, has major sepsis, septic shock, organ failure, any organ failure. Those patients tend to be catabolic. The body is just breaking down its reserves. It's breaking down its protein reserves, fat, glycogen reserves. By giving parenteral nutrition, you're not going to be able to stop the catabolism because it's more a pathophysiology. But you'll be able to help the body rebuild or prevent a lot of losses. The losses will happen, but you counteract, you minimize the impact of this catabolism on the body as a whole. Of course, when you give protein, you're building tissue, you're trying to build tissue with the help of insulin that puts them into, the tissues. Think about the proteins not only as a muscle mass, but as a major component of enzymes. Good nutrition also supports good immunity. If somebody has wounds, whether it's a surgical wound or trauma wound, burn wounds, so to rebuild those tissues, i.e. the wound to heal, you need to provide enough proteins. Typically, in our design of parenteral nutrition, we aim at the amino acids providing close to 10 to 20% of the daily calories, which means if you have a patient who requires 2,000 calories per day, this is the same patient who weighs, let's say, 70 kilos. Around 20%, 15, 10%, it depends on the kidney and the liver function, should come from these calories. If you want to shoot for 20%, so out of the 2,000 calories per day, 400, i.e. 20% of the 2,000 would come from the amino acids. And remember that each gram of amino acids you give will give you 4 kilocalories. This is important when you count the calories from the different macronutrient sources. Just a ballpark idea is that an average adult person, you, everybody, will need about 1 gram per kilo of protein per day. But somebody who is in the intensive care unit, somebody who has major wounds, and their kidneys are okay, we go higher. We go to 1.5 gram per kilo. We go to sometimes 2 gram per kilo. In children, of course, we can go much higher to 3 or 3.5 gram per kilo, but that's a different story. Our focus today is more the adult population. But when someone has a liver failure, end-stage liver disease, and kidney disease not receiving any type of dialysis, you try to minimize the nitrogen load that's coming from the amino acids. You stay a little bit less than 1 gram per kilo at 0.6, 0.8, or 1 until you have either dialysis working for the kidney patient or the end-stage liver disease, the hepatic encephalopathy has resolved. So this is pretty much for the amino acid as one component of the 3 macronutrients. Now comes the dextrose. If you think about the dextrose, it is the major source of calories, not only in parenteral nutrition. And when we give parenteral nutrition, we try to a great extent to simulate our normal diet, normal eating pattern. Okay, so a typical diet, it's not like specific to a person who's having special diets or doesn't have a proper diet. We typically consume in part of our nutrition, about 50 to 60% of our nutrition comes from the carbohydrates. And this is similar in the TPN. In the parenteral nutrition, this source of carbohydrate is the dextrose. We call it dextrose because it's the D-glucose. In the bloodstream, we check blood glucose. What we give to the patient is the dextrogir glucose. We call it dextrose. So it is a major source of energy. Remember, for the proteins, it's about 10 to 20% of the daily calories. For the dextrose, at least half of the calories, if not 60%, would come from the carbs. Here is the case of the dextrose. Definitely, it is a major source of calories, but also it's immediate. It's immediate. Why is it immediate? Because the body goes to the immediate source of fuel trying to heal itself, trying to keep us alive. And the dextrose comes in so handy, so handy. Think about a person who's diabetic, let's say, and becomes hypoglycemic for whatever reasons. We have several reasons why. You give them just any type of sugar, and it's just a matter of a few minutes. You'd see them coming around nicely. So it's immediately utilized. And nature has done good things. If you look at the screen here, I talk about tissues that are dependent on glucose for energy. The central nervous system, CNS, the red blood cells, RBCs, the white blood cells, white count, the WBC, and the renal medulla. All those tissues do not depend on insulin to get the glucose. And this is good for our survival as a species. You don't need a mediator. You don't need the insulin to help you for these tissues to get the glucose. So this is very important. And these consume a lot of the dextrose we give to maintain life. And when you talk about the energy source, yes, it is a major source of energy. It's immediate. The body thrives on glucose. And 1 gram of the glucose is 3.4 kcal. Now you may wonder, well, I learned in nutrition, or I read, 1 gram of carb that I take orally is 4 kcal. Why am I saying here 1 gram of dextrose, which is the IV, intravenous? It's in solution. Why is it less than 4 kcal? It's exactly 3.4. It is because of the nature of the carbs, carbohydrates, i.e. the dextrose, that is not 100% dextrose. It's dextrose in water. So when you calculate the IV dextrose calories, 1 gram is not 4 kcal, it's just 3.4 kcal. Again, because you have the glucose molecule that is bound, part of it is water because it's into solution. So the dextrose is a source of energy. It also helps us with cellular metabolism. It helps us spare our protein. So our body would not go to the proteins, its own proteins, to derive energy. So it sends messages to the brain: spare your good proteins, spare the proteins for your vital organs, such as the heart and other vital organs. Use the dextrose as a major and immediate source. And of course, dextrose is major for our cells, for our enzymes, for body functions. So the third and also important source of calories as part of the macronutrients, after we have covered the amino acids and the dextrose, are the lipid emulsions. We can call them also intravenous fat emulsions. They refer to the same. It's a matter of preference. So this is fat that we give intravenously to have a balanced and complete nutrition. All of these macronutrients in proportional amounts are necessary for proper metabolism, tissue building, growth, preventing malnutrition, and weight loss. So these are tricky solutions, as you know by now. These are emulsions, i.e. oil in water. They're sensitive when it comes to compatibility and stability. You have to be careful about them. They can more easily support microbial growth. That's why we infuse them over typically 10 to 12 hours, 14 hours, because they are more so of an isotonic solutions with a pH close to neutral, anywhere between 7 to 8. Otherwise, the other components of parenteral nutrition tend to have a pH that's acidic, and they tend to be hyperosmolar solutions. So you don't worry as much about bacterial or fungal contamination of these solutions, but the lipids are more so of a problem. All of them are concerning because you have to use those solutions very carefully, compound them under sterile conditions because they can support microbial growth. More so are the lipid emulsions. And this is the reason why we infuse them over a short period of time. The rest of the TPN can go over 24 hours. We prefer the lipids to run slightly over a shorter period of time to avoid this risk of contamination and possible infection to the patient. So why we give fat or IV lipids is because we need to provide people with another source of calories as is in our normal diet. Our normal regular diet would have the protein sources, the fat, the carbohydrates, and we come to the vitamins, the fiber, etc. But we don't give fibers IV, of course. So what's in these emulsions? They have the long-chain triglycerides, okay? And some of them do have medium-chain triglycerides. They used to be investigational, no more. I will get to an example. Historically, the main source of IV fat هي the soybean oil. زيت الصويا المكرر إذا بدكم تقولوا. And here I remember a case back in the days when I was still in the United States working. The farmers who used to grow soya يعني حبة الصويا, a lot of them they decreased their production of soy and they started growing corn instead. So in the US there was a shortage of IV lipid emulsions because the farmers were not planting or supplying enough soybean anymore to extract the oil from it to make the emulsions. So the US was resorted to importing it from abroad, from Europe, from other places in the world. Very interesting story. So the soybean oil is the major source of our oil here in the intravenous lipid emulsions. It has a problem. The problem is it has proportionally a lot of omega-6 fatty acids. And you know omega-6 compared to omega-3. Omega-3 is more immunomodulatory. Omega-6 causes the reverse effect, adverse effect to the immune system, the inflammatory process, etc. So we're still using them in large amounts. They have easy access to their sources. In most patients, they're just fine. They don't cause any harm whatsoever. In a proportion of patients, a small proportion, those who get TPN for the long term, those who have liver disease, we would be worried about the soybean alone causing liver problems. Other than that, they're good formulas, relatively affordable price-wise to use. So if you look at the bottom of the screen, before we get to that, the greenish table, I mentioned something called the SMOF lipid. SMOF lipid has gained popularity worldwide, although it remains more expensive than just the soybean oil. Again, you can use soybean oil-based formulas for the majority of patients, no issues at an affordable price. However, we have this SMOF lipid, and it's easy to tell what it means. The SMOF, look at the SMOF only. The S stands for soybean. It's mixed with MCT, I mean medium-chain triglycerides. It has some olive oil in it, okay, all mixed together, and a fish oil. Fish oil is a major source of omega-3, all right? The medium-chain triglycerides are easier cleared from the body by the blood in the bloodstream and the liver than the LCT, long-chain triglycerides. Still, we need the soybean oil because the soybean oil is an essential source of linoleic and linolenic acid, and these two are essential fatty acids that our body doesn't make. We need to give them exogenously. So this is easily provided here in this formula. So the good thing about this formula, it doesn't rely only on the soybean, but it has a mix of easily metabolized triglycerides, MCT, monosaturated or polysaturated type of fatty acids from the olive oil, and the fish oil that is a major source of omega-3. So you have a more balance of omega-6 to omega-3, whereby minimizing the chances of any possible inflammatory mediator or any inflammation that may happen as a possible cause of omega-6. The way you dose the lipids is based on the volume you give, the calories per volume here. If you noticed, when I talked about the amino acids and the dextrose, we talked about kcal per gram. Now, why am I here talking about the per milliliter? The best way to look at the calories from the lipids, whether it is a 10% formula, a 20%, or a 30%, this is all in water. It's all in water percentage. And when you say 10%, it's 10 gram in 100 ml, 20%, 20 gram of fat in 100 ml. Why is it per ml? Because in the formula, we add certain agents to adjust for tonicity, i.e. the glycerin. Remember, glycerin is a glycerol, is a sugar. And we add some egg phospholipids. So by the mere fact you have an IV solution, you're not getting only the pure fat. You know, when you can calculate the calories from the oral diet, from the regular diet, of course. You say 9 kcal per gram. Why do it exactly 9 kcal per gram of IV fat? It's again not so accurate because in the solution we have fat plus have some other elements such as glycerol that add calories here. Please keep these in mind if you want to be accurate in your calculation. So this is so far what we talked about in terms of macronutrients. I move on quickly and on them became about. Europe should have its own safety procedures, policy.
دكتورة سليمة، أتصور النت فصل يم دكتور عماد لأن اختفى.
دكتورة كوثر بالضبط ما موجود عني.
مو
مو موجود. أنا بانتظار.
تمام، هسه خل نشوف 10 دقائق ويرجع إن شاء الله. إن شاء الله. تسلمين دكتورة، شكرا.
Hello. Hello again.
أهلا دكتور عماد، تمام نسمعك.
نعتذر إنه we got disconnected.
Yeah, it's fine.
Would you allow me please to share screen again?
اي تمام. هسه دكتورة سليمة تسوي الكوهوست. اعتقد اوكي دكتورة، هسه تقدر حضرتك تشير.
اوكي، مش الحال هلا؟
اي تمام.
تمام، قصدي ما ترخصوني على القطع. بقى حكينا عن الماكرونيوترينتس وعلى الفلويد الكترولايتس، وهول كثير مهمين الالكترولايتس بالفارماسي. عندكم policies and procedures to put a limit of how much you give. So what are the electrolytes that go inside PPN? The sodium, major source. You can add it as a chloride or acetate. Or potassium, which is the riskiest electrolyte, and it can cause a lot of cardiac problems. بيجي again as chloride or acetate. By default بتاعته sodium chloride or potassium chloride as a standard. ليه؟ لأنه الchloride is handled by the kidneys. You don't risk any issues unless you have problems with the kidneys, and the chloride would accumulate to cause hyperchloremic acidosis, which is very rare. بس الacetate
بعد يوجد composition in the hospital. Every day they assess the patient, the nutritional needs, and then they send it to a special company to produce the TPN required for that patient to be infused over 24 hours. This is done daily. So لأنه صارت عندهم حالات من يعني safety concerns, so they delete that option. They only do that for in special hospitals or in special companies for TPN. فما عرفوا يعني يمكن أيضا يتم هذا الموضوع أو لا.
اللي حكيتيه هيدا كتير صحيح. هيدي أنا خبرتي جاية من أمريكا. وقت اللي كنا نعمل الكومباوندينج بقلب المستشفى كان عندنا أوتوماتيك كومباوندر، ومثل ما سبق وتفضلتي كل يوم التي بي ان اوردر لازم واحد يكتبه ويعمل له ريفيو من بعد ما يطلعوا اللابس تبع البيشنت الصبح، بيسحبوا الدم، بيطلعوا فحوصات الدم، وعلى اساسها بيرجعوا بيحددوا شو طبيعه التي بي ان اللي بدنا نطلعها اليوم بالفارماسي ونعمل لها انفيوجن اوفر 24 hours. هذا اكيد بشكل ثقل على الصيدليه تعمل كومباوندينج، بس بالحقيقه عندي كنترول بقلب المستشفى، بس مكلف لحد معين. بنفس الوقت الستيريليتي منا سهله تو مينتين، حتى لو كان عندك كومباوندينج اني لامينال فلو هود والى اخره. قبل ما تركت انا امريكا بكم سنه وقفنا هذا الشيء، ما عدنا نعمل التي بي ان بقلب المستشفى. صار عندنا اوت سورسينج مثل ما تفضلتي وقلتي انه في كومبانيز متخصصين لستيرل كومباوندينج، نبعث لهم الاوردر الكترونيكلي، هن بيعبوه بيشحنوا لنا اياه بسرعه وبيوصل للمريض بعد الظهر لعنا. وهودي متخصصين مع اتموست ستيريليتي، يعني عندهم اي في روم ما بتعمل الا ستيريل كومباوندينج، اختصاصهم هالشيء. هذا وفر علينا مصاري بوقتها بالمستشفى بميشيغان، وفر علينا مصاري كثير، وكنا متاكدين انه هن عندهم ستيريليتي كومباوندينج ليفل كثير متطور اكثر من احنا عندنا اياه باللامينر فلو هود او بالاوتوماتيك كومباوندر. هلا برجع على البري ميكس باجز. ما هي القصه وين؟ انه يس ممكن they fit the size of 80-90% of the patients. بس البري ميكس باجز بنفس الوقت ما فيك يعني تايلر ميك ذم، انه جايين مثل ما هن، تعملون اكتيفيشن على البيد سايد النيرس وبتعلقوا، بس بدك تعملي اي ادجستمنت للكالوريز، اي ادجستمنت للفات، يعني بارت اوف ذا كالوريز اكيد لدك ما فيك، لانه مثل ما جاي بدك تعطيه الكترولايتس كمان. بقى لهم ادفانتجز كثير بري ميكس باجز، والمستشفيات خففت عبء الشغل عليها، لانه عم بيجي حاضر وعندك 80% من المرضى عم بيستفيدوا منه، بيبقى هال 20% الباقي بنعمل له اوت سورسينج او كومباوندينج اون ان از نيد بيسس.
نعم. طلبتنا الاعزاء، اكو اي احد عنده استفسار اخر من الدكتور؟
اهلا وسهلا، اذا عندكم شيء تفضلوا.
تمام. ما أعرف. يتشكروك دكتور.
أنا بتشكر أكيد. أهلا وسهلا، كل غرض يلزم شو في يساعد أنا حاضر. مثل ما سبق وقلت أنا النيوتريشن سبورت هيدي عليها مهنيا يعني 32 سنة تقريبا من الخبرة، ويلي خلتني أوصل بمجالات عديدة وربي علاقات عامة، وأقدر كمان أعمل ريسيرش حواليها وأعمل بابليكيشنز. فمشان هيك بحكي عنها بشغف،
طبعا.
وأي شيء في يساعد فيه بحب أعطيها من كل قلبي، لأنه بالحقيقة شيء بحبه كثير.
الطلبة جميعا يتشكرون حضرتك.
بتمنى هالاجيال الجديده كمان، بتمنى هالاجيال الجديده اللي جاي تفكر انه تهتم بدور الصيدلي اللي ممكن يلعبوا دور كبير بالبارنترال نوتريشن. عنده دور الصيدلي كثير كبير بهالمجال.
نعم.
وهالاجيال الجديده اللي طالعه هي تتحمس وجت انفولد اكثر بنطاق البارنترال نوتريشن وغيره.
نعم. احنا نحاول بالطلبة عندهم تدريب المستشفيات، فنحاول ندخلهم الى التي بي ان، بس لانه المكانات اللي تتحضر بها should be sterile، ف we cannot take whole students. عندنا ما شاء الله اعداد كبيره، ف يعني ممكن انه اعداد قليله فنراويهم مساله التي بي ان وتحضير التي بي ان.
ضروري حتى لو باعداد صغيره، بركي بيقدروا هن بيكملوا هالمسيره اللي مهمه. ما تخلوها تروحوا من ايدكم كصيادله. الصيدلي عنده دور كثير مهم بمجال النوتريشن. انا بالواحد 92 وقت كنت عم بتخصص بامريكا، يعني قبل ما خلقوا اكثريتهم هالشباب والصبايا عندكم، كنت اسال حالي شو دور الصيدلي. بس لما تدربت بالريزيدنسي عليها حبيتها، يعني انغرمت فيها لهالمهنة.
طبعا أكيد أكيد. دكتور، طلبتنا كلهم يتشكرون حضرتك على النايس ليكتشر والانفورميشن administered here. فإن شاء الله. وأنا أيضا أتشكر حضرتك على وقتك الثمين اللي قضيته معنا this evening. أتشرف بحضرتك. معروف دكتورة كوثر إذا كان عندك.
أي نعم دكتورة موجودة. لا بس نشكر دكتور عماد، شكرا جزيلا دكتور على تثبيتك الدعوة يعني بسرعة حقيقة، كل هالتايمز يعني كانت الترتيب جدا سريع. ممنونين جدا من حضرتك.
بتشكرك أنا على هالفيدباك، وبتمنى لكم كل التوفيق لكم ولتلاميذكم ولبرنامج الصيدلة عندكم. وإذا بتعتزوا شيء بعد بقدر ساعد فيه خلوني أعرف
إن شاء الله. بس أنتظر من حضرتك يعني الهاند اوتس.
أكيد هلا بس سكر معكم ببعث لك إياها.
إن شاء الله.
شكرا
أمسية سعيدة لكم جميعا. يلا تصبحوا على خير.
جميعا شكرا.
جزيلا.
شكرا دكتورة سليمة، شكرا دكتورة بسمة.
شكرا لكم دكتورة.
شكرا لكم آني.